Antimicrobial resistance poses a formidable challenge. I will not quote statistics. We'll have plenty of them coming up here as the evening progresses. I will say this though. Antimicrobial resistance threatens to nullify the gains made over the last 50 years and will, if not checked aggressively, usher in an era where humans are left defenseless against life-threatening pathogens. A frightening prospect, I must say. I do realize a proper discussion on AMR is beyond me. So I will duly excuse myself and give over to the pleasure of inviting Dr. Manthan, Chairman, Institute of Critical Care and Anesthesiology, Medanta, the Medicity, and Chairperson, Manthan 2013, to deliver the welcome address. Sir, if you could come up to the dais, please. I would also request Mr. Kumud Handa, CEO of Venus Remedies, to escort Dr. Manthan to the dais.
Welcome you all. Nice to see that at least the hall is full. When I came in, there were hardly any guys around. I think it is my pleasant task to welcome you for this evening session. Whenever they talk about severe sepsis, I think they talk about the golden hour. We have an interesting evening ahead. MDR pathogens is a very major, increasingly so problem in India, not only in major tertiary care hospitals, but in all over, wherever the ICU and critically ill patients are there. It is pandemic and it is increasing tremendously. Acinetobacter, which we hardly used to see 3-4 years back, is increasing. Klebsiella, E. coli are becoming MDR pathogens. Colistin is still effective, but carbapenems producing organisms are significantly increasing. We do, all of us now see carbapenem resistance in our ICUs, and it's a major problem because the drugs are so expensive, the ICU stay is prolonged, the mortality, morbidity increases, and the outcome can be questionable. So, without wasting too much of time, I would like to thank you all and look forward to a pleasant, good evening. Thank you. There is his talk about the publication. It reminds me of a little story, just to break the monotony of this conversation. This is an adopted story from some other speaker who was in the same session where I was, a surgeon. So he said that there was a surgeon who was in Saudi Arabia, and his patient died on the table. So he was arrested, he was thrown in a cell. For the rest of his life, he was supposed to spend in that cell. And there was a cellmate of his, in the same room, and he was very quietly sitting there. Now the surgeon was getting restless. He couldn't imagine spending the rest of his life in a cell like this. So he found some small file, and all night he sort of started cutting the walls of the cell, and he broke through it, and he went to the desert, running. He tried running for 10, 20, 30 miles, and finally they sent the choppers and they caught him, they beat him up, they put him back and threw him back to the same cell. So when he was thrown into the cell, he asked the other cellmate who was sitting quietly earlier, he said, I knew this was going to happen. He said, how come? He said, well, I tried the same thing last year and this is what happened to me. So he said, if you knew this, why did you tell me this is going to happen? He said, I am a microbiologist, I have never published. So I think we need to get out of this. We need to have our own data about what we should do. Any questions from the audience?
Yes, sir.
Yeah? Don't feel shy. Dr. Alok from Apollo Delhi. Antibiotic synergism improves efficacy. While de-escalating, how should we deal? There are two questions, I suppose.
This is the one question only.
Yeah.
You got 2-3 antibiotics. I'm Dr. Alok.
Yeah.
And you started. Now the culture comes, which got positivity for 2 like amikacin or carbapenem.
Dr. Alok from Apollo Delhi. Antibiotic synergism improves efficacy. While de-escalating, how should we deal? There are two questions, I suppose.
This is the one question only.
Yeah.
You got 2-3 antibiotics. I'm Dr. Alok.
Yeah.
And you started. now the culture comes which got positivity for 2 like amikacin or carbapenem. So which antibiotic would you like to keep, both or just to continue one of them?
So basically de-escalation has to happen, and as I said during my talk, de-escalation could mean going from broad spectrum to a narrow spectrum, going from 2, 3, 4 drugs to 1 drug. Now, if the 3 drugs which you are using and the culture shows that it is sensitive to all 3, it is left to your good judgment to decide which of the 3 would you like to use when you are de-escalating. Now, if I am given a choice between amikacin or meropenem, and the culture is showing same MIC and same sensitivity to both, and the person is getting better, there is really nothing to choose between the two, and amikacin probably is equally effective. So choose amikacin. It is less expensive for the patient and less burden you will be creating for MD resistance subsequently. But de-escalation has to happen. The problem happens if the culture doesn't show up anything, your patient has improved. Then what do you do? That's a bigger problem. Then whether you choose amikacin or meropenem or whatever, then it's a bigger problem. Out of 3 drugs, whether you de-escalate, not de-escalate, and remove one. If the culture is showing sensitivity pattern to all 2 or 3 of them and you have to choose one, it's not a problem. In that case, depending upon the scenario the patient is in, it's a hospital-acquired infection, he has risk factors for MDR bugs, probably I would leave him on carbapenem and remove the other ones. But that's more of a hit and run. And again, it would depend upon what is the focus, what is the site of infection, and what are the presumed bugs which this patient will be suffering from. So that's how I would handle this patient.
The usual time frame you want to continue with your antibiotics. Suppose the patient gets response in 4 days, 5 days. So you would like to continue in the 7 days.
We conducted a randomized controlled trial in COPD patients using procalcitonin to guide our antibiotic therapy. So in 50 of those patients where procalcitonin was negative, we did not give any antibiotic. If it was high, only then we gave the antibiotic. In the remaining 50, whatever the usual practices are, because COPD is always, an acute exacerbation of COPD is always expected to be associated with a bacterial infection, although only 50% are due to bacterial infection. Remaining could be due to viral pathology, due to an exposure. And we found that in the procalcitonin group, the antibiotic reduction was nearly 71%. There were only out of 50, probably only about 10 or 12 patients who required antibiotic because the procalcitonin was high. In all others, we discontinued the antibiotic and the end results were almost the same. The amount of steroids that were used, the BiPAP in non-invasive support that was used was the same. The PFTs were the same. There was no difference whatsoever. So procalcitonin is emerging as a very good marker for at least de-escalating the antibiotic.
When we say that we receive patients from peripheries who may have been treated with antibiotics earlier, and when they come in with a bad sepsis, if we do a procalcitonin at that time, and we are very likely to get culture negative reports coming in from microbiology. So in these situations, as the procalcitonin drops by about 80%, it's a good time to be able to stop your antibiotics when you do not get culture positives. But like say the patient came in with a procal of 100, and you do it after 4 days and you're 40, and then after another 3-4 days you're at 10, and you can just stop your antibiotics. It works great.
Okay, I think we have some more talks to go ahead. I would thank my panelists for an excellent discussion and the audience. And I hand over the mic to Dr. Paul again. Thank you very much.
Thank you very much. Several interesting points being made here, but I would specifically refer to what Dr. Nangia pointed out. We don't have enough antibiotics for gram-negative infections now. Well, sir, with today's conference, we hope to change that. We'll be showcasing some work done in this area where we will have several interesting points being made here, but I would specifically refer to what Dr. Nangia pointed out. We don't have enough antibiotics for gram-negative infections now. Well, sir, with today's conference, we hope to change that. We'll be showcasing some work done in this area where we will have a product here that deals specifically with gram-negative infections. Basic answers, we'll do well to remember that there can be no one solution. A number of possible solutions have to blend seamlessly, and a multi-pronged strategy has to emerge. Having said that, it is equally important to ensure that all aspects of the problem are addressed simultaneously. And as I have been talking about the work done, This is precisely something addressing all aspects of the problem. This is precisely what has been at the core of Venus Medicine Research Center's efforts over the years. Research-based solutions to AMR has been a recurring theme at VMRC, and over the years, VMRC has done some outstanding work in this area. Research and innovation apart, VMRC has also been rooting for a comprehensive strategy to deal with AMR on all possible levels. Having said that, I think now it is time for me to invite Dr. K.N. Prasad, Professor, Department of Microbiology, SGPGI Lucknow. Dr. Prasad will talk about Indian innovations for the global AMR concern. Sir, please.
So, thank you very much for giving me the opportunity to talk over this August audience. So, I have talked MDR gram-negative infections, crisis versus innovations. So, you know that crisis is tremendous, but innovation is almost nil. If we talk of innovation, we means that जैसे हिंदी में कहावत है जे एक बोतल का शराब दूसरे बोतल में डाल देना है. That is only the innovation. We don't have any new class of antibiotics coming up. Whatever is coming up, only the side chain modification of the existing antibiotics or combination of the known molecules to have a better effect.